Hi, I'm Lauren Henke, and welcome back to another NRG Oncology podcast episode. I'm joined today by my co-host, Stephen Chun, and today we have two guests with us. One is Dr. Karyn Goodman, who is a gastrointestinal radiation oncologist and vice chair of radiation oncology for the Tisch Cancer Institute at Mount Sinai Medical Center in New York.
And we're also joined by Dr. Ross Abrams, who comes to us all the way from Israel. Dr. Abrams is the principal investigator of RTOG 0848 that we're going to be focusing on today, and is the recently retired chair of radiation oncology at Rush University in Chicago. Dr. Abrams, how is life in retirement?
I recommend it highly. I worked until I was just about 71. As you know, I had two careers in medicine. I had one in internal medicine, medical oncology, and then the second one in radiation oncology. The first, I think, prepared me excellently for the second, but the second was my true love.
And so on that note, this is a very unique career path. Starting off in medical oncology, going to gastrointestinal radiation oncology, what motivated that transition, and how did that end up getting you involved in RTOG?
The medical oncology selection occurred after I started out with internal medicine. So you might ask, how did I choose internal medicine? I loved everything in medical school. Unfortunately, it did occur to me that I couldn't specialize in everything, although if I had been given the opportunity, I might have tried. I was strongly imprinted by my first mentor, Dr. Arnold Rellman. That may not be a name that everyone remembers now, but Dr. Rellman, among other things, was a world-famous nephrologist, the chairman of medicine at the University of Pennsylvania, which is where he became my mentor, as a first-year medical student teaching history, taking in physical diagnosis as the chairman of the department. I was really imprinted about the significance and attraction of internal medicine. Once I actually went into internal medicine, I began to experience it, plus had some life circumstances of my own, including my mother getting breast cancer. I was pulled to medical oncology and trained in medical oncology at the University of Pennsylvania. And I can say that back in the day, we're talking about 1973, 74, 75, 76. I didn't meet any radiation oncologists, at least none that I remember. But as part of my medical oncology training, I went to the NCI. And in 1978 at the NCI, when I was still there, Eli Gladstein became the chairman of radiation oncology there. And this was as if my whole universe was expanded. Eli was amazing. He knew more about lymphoma than the medical oncologists who were specializing in lymphoma at the NCI, or at least as much. And he could hold his own against the likes of Vince DeVita and Dr. Fisher, and among others. The more I had contact with Eli, the more radiation oncology became an attraction. Then when I left the NCI, having stayed so far in medical oncology and research, I went to the Medical College of Wisconsin, where at that time was probably the most amazing department of radiation oncology that a person could imagine. The chair there was Jim Cox, but the other people there included Larry Kuhn, Roger Beihard, Frank Wilson, who later went on to become the chair. These were all incredible people and all became leaders. I was sold. So after a couple of years, I went down and spoke to Jim. At the time, I was an assistant professor at medicine in Mannock, and I said, Jim, I think I want to become a radiation oncologist. And to my astonishment, he said, I've been waiting for you. And so that's how I became a radiation oncologist. I retrained, worked with the board to get some credit for my prior experience, and becoming a gastrointestinal radiation oncologist, that had to do with going to Hopkins as an early career in radiation oncology job, and having the opportunity to work with an amazing group of pancreatic and hepatobiliary surgeons under the leadership of John Cameron, and his group included people like Keith Lillimo, who's now the chairman of surgery at MDH, and Charlie Yeo, who's now the chairman of surgery at Jefferson, and these, among others, and these were extraordinary surgeons. And fortunately for me, Dr. Cameron was a fan of radiation oncology for the malignancies upon which he operated on. And this was an opportunity to develop a niche that I seized and worked in partnership with the surgeons and became, over time, part of their team.
I mean, what an amazing history. And, you've clearly seen it all, I'd argue. Especially a cancer like pancreatic cancer, they call it the emperor of all maladies. It's really true. This is a cancer that we've hardly budged the long-term survival in 50 years. Before we get into the details of RTOG-0848, I'm wondering if you could first talk about the management in general of resectable pancreatic cancer and perhaps some of the seminal trials. I remember being in medical school 20 years ago when RTOG 9704 came out, and people were just incredibly happy that the needle had been moved forward, even in a very small incremental way. And if you could just talk about this as a segue to RTOG-0848.
I think what you have to remember about pancreatic cancer is that over the years, everything has been hard. If you wanted to find an organ that's a very difficult organ from which to make a diagnosis, where would you put it? You would bury it deep in the upper retroperitoneum, surrounded by lots of vasculature and lots of critical organs that could only be approached with trepidation. It wasn't until the very late 1980s that the surgeons, including Dr. Cameron, but not exclusively, in a number of centers, really learned how to do safely a pancreatic adduodenectomy. When I was in medical school, the 30-day mortality from a Whipple was 30%. And the argument wasn't, what's the best way to operate? The argument was, should anyone operate on? Because it may be, in the eyes of quite a few, that trying to treat the cancer was worse than the cancer itself, even though everyone acknowledged that the cancer was terrible. But the watershed event, really, that permitted considerations of adjuvant therapy was the ability to operate safely and reduce that 30% 30-day mortality to 1%, and the morbidity to a management to people who, instead of being in the hospital for a month, if they survived, were out in a week and a half or 2 weeks. At that point, it became possible to ask, well, what are we doing? What are we accomplishing with the surgery? And the data were disappointing because 90% plus of people were relapsing within 3 to 5 years. So you would take someone, put them through this incredible operation, a technical triumph. Of course, the someone was only 15 or 20% of all the patients with pancreatic cancer. And then they would say, wow, okay, my cancer's gone. What lies in front of me now? And unfortunately, it wasn't very encouraging.
And so this is really great background. And with this in mind, I'm wondering if you can take us back to 2008, when RTOG-0848 got off the ground, and speak to us about the conversations and the maneuvering it took to get this trial open.
Well, memory is a pretty fallible thing, and so I don't want to tell you that I remember exactly, but let me set the context. In 2001 and 2004, the SPAC trial, SPAC-1, was published first in Lancet, not to be confused with Lancet Oncology, and then in the New England Journal of Medicine, respectively. And what this trial purported to show was that while adjuvant therapy with chemotherapy was beneficial, adjuvant therapy with 5-FU sensitized radiation was detrimental to the outcome of patients. And so the medical oncology community jumped all over this and said, we're not going to use radiation. It's dangerous for patients. Even though there were many questions about the SPAC-1 trial, the outcome was the outcome. It was reported in very prestigious journals, and it was greatly embraced by the medical oncology community. 9704 had truly been a watershed event because it was the first modern trial since the very old GI tumor study group trial, which, although you can find it in almost all the textbooks of that generation and since, was really something that raised more questions than it answered. And by modern day considerations, it was not be considered a very robust trial for sure, with lots of criticism. But it did show that 5-FU sensitized radiation, in addition to surgery, seemed to be better than surgery alone. 9704 was built upon that, and the watershed event of that time was the recent development of gemcitabine. You know, when I was in training, the only drug we had for pancreatic cancer was 5-FU, and the quip was, well, the only drug that works in pancreatic cancer is 5-FU, and the only problem with 5-FU is that it doesn't work. And so, you know, we were all pretty cynical about chemotherapy, but then gemcitabine came along, and this was a dramatic event. It was the first breakthrough in pancreatic cancer in decades on the chemotherapy front. And so that's how 9704 was designed, with a sandwich of chemotherapy before and after chemoradiation, and comparing 5-FU versus gemcitabine. I would say the most important thing about 9704, well, actually, it would be two important things. One, we began doing modern trials in the adjuvant therapy of pancreatic cancer, and this is really to the credit of Bill Regine, who invited me to partner with him in 9704. And the second thing was that the secondary analysis of 9704 really set the stage for the next trial, which became 0848. Now, I want to say that, getting back to your question, that in 0848, the situation was radiation and radiation oncology had all but lost our foothold in the adjuvant management of pancreatic cancer. I wanted to propose a trial through the Pancreatic Cancer Task Force, of which I was a member, and the only proposal that got even a hint of traction was a trial looking at chemo without radiation plus chemo plus radiation. You know, that's a very hard trial to do. If you go back and think about the McDonald trial in gastric cancer, okay, that was a trial that compared surgery alone in gastric cancer versus surgery plus adjuvant therapy, which included chemotherapy and radiation. Well, that trial, while it was really a very impactful trial when the results were published in a New England Journal, took 12 years to accrue the patients, because it's very hard to sell nothing versus something, especially for patients who were interested in getting the best possible outcomes. And the bias is always that the something is better than the nothing, whether it's correct or not. We had that problem with 0848, but the trial needed to be done because otherwise I think the game was lost. The trial was designed to be a chemotherapy randomization and then a radiotherapy plus minus randomization at the end of the chemotherapy. When we presented the chemotherapy results, which were negative, at ASCO in 2017, one of the questions I got was someone stood up and said, how could I ethically randomize patients to radiation oncology? I think the exact question was, did I think it was ethical to randomize patients to get radiation therapy in 2017? One of my medical oncology colleagues who was on the same panel with me stepped in to give a very supportive answer, but it was long-winded. And when she was done, I said, I'd like to answer now. My answer is yes. And that was all I said. Fortunately, if you know what 0848 has shown, as Karyn presented at the ASCO meeting this year, I was right. I have to say it was good. And from my perspective, I didn't really think I was taking a high-risk venture, because I have always believed that when you look at the patterns of failure for pancreatic cancer, it should be self-evident that if chemotherapies accomplish anything, radiation will be needed to enhance local regional control. And so that was the context in which 0848 was born.
That is a perfect setup to our next question, really, which is, Dr. Goodman, as we transition to talking about the results of 0848, For those of our audience members who aren't familiar with the structure of the NCI as it relates to NRG, could you tell us how NRG fits within the larger NCI mission and give us a high-level overview of how trial concepts like RTOG 0848 crafted within the NRG oncology group and then navigate through the NCI to become active trials? How does that work?
That's a great question. It's a very complicated process, and I think it's important to sort of, in a simplified way, to give you the context and this sort of landscape. So the NRG is one of 4 adult cooperative groups in the NCI's National Clinical Trials Network, or NCTN. We are actually a composite of previously 3 different cooperative groups. So there was the RTOG, so that's why the 0848 study was originally called RTOG 0848, and that was primarily the radiation oncology group, the GOG, which is the gynecologic oncology group, and the NSABP, which was more of a medical oncology group that focused on mostly breast and colon cancer studies. So we have this really great composite of different groups that bring a lot of expertise from these multidisciplinary areas. So in terms of how do we develop concepts are usually developed in the very early stages with a group of, so we have many subcommittees. So say for the GI committee, we have subcommittees on anal cancer, on esophagogastric cancer, and junior faculty oftentimes will come to the subcommittee and present an idea and get some feedback at that stage. There are actually multiple time points where you can get feedback, which is great because I think ultimately we want to develop a trial that is going to be as successful as possible and answer the question. Once it's been sort of vetted through the subcommittee, it's then presented to the committee and get, again, lots of feedback. The group comes back maybe a few times to discuss the study. And then ultimately the committee chair for GI would be Dr. Ted Hong, would then decide, yes, it can go ahead with the next step. And that's the GI non-colorectal committee. And so at that point, it would be submitted to the NCI task forces. And so again, each group is a little bit different. Each disease area is a little bit different, but within GI, we have multiple task forces, each focused on a different disease site. In, 2024, they would submit to, say, the pancreas task force, and then it would be a group of representatives from all of the different cooperative groups who have expertise in that area. And they would present to the task force, and the task force would then give feedback both on the scientific merit, the design, but also to make sure there's not overlap between the different cooperative groups, to make sure that we're not, having NRG and Alliance both coming up with similar overlapping concepts. And then once the committee, say NRG, decides that they're ready, they then submit that concept to the steering committee. So the GI steering committee is the group that I'm on. And so at that point, the GI steering committee does a very thorough review. And actually, I'll just say one of the things that's we're trying to do a little bit more is before it gets to GI steering committee, we want to have a more thorough vetting process, because the last thing we want people to do is go through all of those steps. And these are junior faculty. You don't want them to work so hard to get to the GI steering committee and then get the study disapproved. So even at the task force now, we've implemented a process where we have reviewers. They give very specific feedback. Once the investigators have kind of integrated that feedback into their concept, then they go to the steering committee. And again, the steering committee assigns reviewers, and we do a very thorough review, biostatistical review. We have patient advocates that are reviewing. We have the clinical reviews, and we have a CTEP review. So it often takes months and months and sometimes years to get through all of those steps. And our goal is to try to get as many of these studies approved as possible. But there can be different outcomes. You can have, the study is approved, the study is disapproved, and then there's a pending status where we've asked for some changes. So for the most part, I think the goal, and having done this a few times for studies that I've submitted, it is really trying to develop the most, but the design that is going to answer the question, the study that's going to have the best feasibility in terms of accruing patients and being interesting to patients, because ultimately we're financially putting a lot of money into these studies, but we're also putting patients' lives. They're actually participating in these studies, and we want that to be meaningful. After the study is approved through the GI steering committee, it then can move on to being developed into a full protocol. So it's really in a concept stage in the beginning, and then it goes through whatever the cooperative group, say it's NRG, they help with the development process. And that also could take some time, but we've really tried to minimize or shorten that process by having, like, there's a clock that starts and you have to finish it in a certain number of days because CTEP is counting. We really don't want studies to take years to even, write and develop, because it's already taken a long time in that first couple of steps too.
That is an amazing process, very stepwise and deliberate, but also really time and energy consuming. I can see from the discussion with Dr. Abrams why the role of modern chemoradiation in the postoperative or adjuvant setting was an important question to ask and clarify. Can you tell us about the basic design, ultimately, of RTOG 0848, its major goals, and how those actually even changed during the course of the trial itself?
The original design was actually it was a two-step randomization process. And there were two questions being asked. One was to ask the question of whether there was any benefit to adding perlotinib to gemcitabine. And then the second question, as Ross mentioned, was that we are really interested in, the ultimate question was to ask whether there was the benefit to the chemoradiation. I think, as we heard from Ross, that it's often very difficult to randomize patients to studies where you have a question of yet giving a modality or not. It did take time to accrue patients over the period that we were enrolling. And so in that period of time, there are also changes in the landscape of how we treated pancreas cancer. And so the LAP-07 trial was published, and we learned that there was no benefit to the erlotinib. So that was removed as part of the question after we had many of the patients actually accrued to the study. So that was then we just had patients put on the study just to the gemcitabine alone in the step 1. And then after 5 months of their chemotherapy, they were reevaluated for any progression. And then they either received another cycle of chemotherapy, another month of gemcitabine, or were given another month of gemcitabine plus the chemoradiation. And the dose was 50/40 centigray. We had a whole atlas to help with delineation of the post-op fields, because that was also relatively new. We also were allowing for IMRT, which was very new at that time. So it was kind of a lot of areas where we were, having people out in the community. These are a lot of community sites enrolling patients, treating patients with a somewhat newer modality with IMRT, and also with post-op anatomy, which is quite difficult. So we had real-time QA on that study, which I think was really important. So Dr. Abrams and I did the review of every single patient that underwent chemoradiation on that study to evaluate the treatment planning and the contouring, and gave feedback as needed and had revisions as needed. So I think we feel proud that we had a very high quality radiation on that study. And I think that was really one of the key aspects, that we were able to give radiation that was, according to a very, strict protocol. And I think that really was important in terms of the outcomes, and seeing that the toxicity was very minimal.
I would just like to add about the real-time QA. The easiest part was approving the submissions that were done according to the protocol. The hard was the ones that weren't. And in an interest of fairness, I think before either Karyn or I would declare someone needing to be replanned, we would go over it with each other to make sure that we weren't being too harsh, too difficult. And this was a time-consuming commitment, but it was critical to the trial and critical to the well-being of the patients, I felt, based on one of the secondary analysis that I did from 97 equality. And I'd like to thank Karyn very much for her partnership because it was essential to getting this trial done.
What an incredible effort. And although we already got to hear that you were right, get your I told you so moment.
Yeah.
Can you summarize for us the major finding of this study?
The major finding on this trial was, first of all, we took all comers who got through this process. We stratified very carefully to make sure that both at initial step 1, the chemotherapy step, and then again at the randomization to get or not get the 5FU radiation, patients were stratified before the randomization to make sure there was no imbalance between potential confounders, such confounders as post-op CA19-9, performance status, margin status, lymph node involvement. These are very important potential confounders, which most trials did not stratify for or appreciate. For all patients, there was no benefit to adding the radiation, but I hasten to add there was also no harm. And so the idea in my mind, and I think in fairly prospective, randomized, well-done study, radiation therapy, as it should be and can be done everywhere now, using either 3D conformal or more likely IMRT or VMAT, does not hurt patients. We had a mild increase in grade 2 or 3 toxicity, but absolutely zero increase in grade 4 or grade 5 toxicity. And I stand by those data. They're rock solid. I don't want to address the issue of why the SPAC1 trial results are so different, but then I'll just point out that they're well over 20 years old now, and a lot of things have changed since then. Most importantly, 25% of the patients are node negative. For the node negative patients, the addition of radiation almost doubled overall survival, increasing it by 20 percentage points. Those curves are far apart. The inflection point is around 2 to 2.5 years where they separate. And for the overall survival for node negative patients with radiation was about 48%, if I remember correctly. Without radiation was about 28%. And for disease-free survival, it was even greater, with the overall disease-free survival being about the same, 47, 48%, and the disease-free survival for the patients who did not get radiation being, I believe, 19%, as I recall. This is extraordinary to have almost half of any subset of patients with pancreatic cancer surviving at the 50% level at 5 years is, in my mind, an extraordinary development, and it is at least as great, even though it's for only 25% of the patients so far, as any chemotherapy development we've seen to date in the adjuvant or neoadjuvant context. I'm hopeful that the Pancreatic Cancer Task Force will take these results as a signal to move forward with looking at better chemotherapy in partnership with randomization to radiation or not radiation, because I think for all patients, it remains possible that if we can get a stronger handle on the systemic failures, the ability of radiation to enhance local regional control will be demonstrated. I do want to emphasize that by putting the radiation after the chemotherapy, about 35% of the patients fell out during the chemotherapy-only arm. About half of that was from progression. About half of that was from patient choice, probably reflecting the lack of desire to be randomized to radiation based on what perhaps others were telling them. And then there were some people who unfortunately passed away or had unacceptable toxicity from the chemo and decided not to go forward.
Just wanted to add that, one thing that I didn't mention in terms of the changes in the landscape of the therapy during that period of time was, as I mentioned, we removed the erlotinib, but the other thing that happened was the development of FOLFIRINOX in the adjuvant setting. And we actually did, at the very end, add an amendment that allowed for FOLFIRINOX, as well as other combination chemotherapies. And we also allowed for some patients to receive 3 months of chemotherapy off the protocol before enrolling in order to enhance the accrual. But just as of interest was that none of the patients received FOLFIRINOX on that study, even though we did allow it at the very end. And I think that's really important because this is a very different systemic therapy regimen with just gemcitabine alone for the most part. And so, we're comparing the data that we have from a sort of suboptimal chemotherapy approach and systemic approach plus chemoradiation, and then comparing that to the more recent PRODIGE study with the adjuvant FOLFIRINOX. And we're still actually quite similar to the findings or the outcomes for PRODIGE. So I think the question is now, with this new era of FOLFIRINOX, where we do see better systemic therapy, what is the role of the adjuvant radiation? Is it more likely to be beneficial, or is it less likely to be beneficial? And I think that's where it's really important to continue to, ask these questions in this new setting.
But I do want to emphasize, and I agree with what Karyn said, that the one thing's for sure, we will not hurt patients by studying radiation further. And I can't emphasize that enough, provided that the radiation is done correctly according to current standards. And so further quality control and my quality assurance and my way of thinking remains essential for these trials.
Maybe one last question that remains then, and congratulations to both of you in truly what sounds like a Herculean effort over the years, making sure that patients got safe, high-quality radiation. For me, another complexity is also not just the FOLFIRINOX era, but the era of the question of neoadjuvant therapy for these patients too. And I think we don't have an answer to the question yet, but I'm curious if you have thoughts on how do we fit radiation into that picture now for resectable patients before, after?
My own prejudice about that is that the only way to answer that question is by studying it. And I think good arguments can be made for doing it up front, and good arguments can be made for doing it after the surgery, perhaps.
I think we have some emerging data now, pre-OPANC. There's been some data from China that looks at giving preoperative, in Korea, giving preoperative chemoradiation in both resectable and borderline resectable disease. And we're seeing that there's potentially a survival advantage, especially in the pre-OPANC trial. So I think, again, we need to, the doses that they used in pre-OPANC were a little different than what we use in the United States. So I think it's something that we need to study, but it does suggest that there is a benefit to local regional therapy when we're dealing with pancreatic cancer. We know that, in studies, autopsy studies from Johns Hopkins, that 30% of patients were dying of just local progression and local disease. The other thing that I think is kind of an interesting twist is the neoadjuvant chemo. And so giving that FOLFIRINOX up front, which was what we're moving to in many cases, and there's an alliance trial looking at this question, what does that impact in terms of when you look at a patient in the adjuvant setting, or, whether we're going to give radiation in the adjuvant setting, what does a node negative patient mean if you've gotten upfront FOLFIRINOX? And so is that going to expand our potential to treat patients if we have more node negative patients, so that we maybe, have a sign from these patients that had upfront FOLFIRINOX that their potential for systemic spread is lower now, so maybe they would benefit from the radiation. So that's another thing, is how do we use the information that we get from the pathologic data in patients that got preoperative chemotherapy. So I think there's still a lot of questions. It's almost created more questions than it answered, but it's certainly, I think after all these years, to see that there was a benefit and that was safe really is very reassuring, and that we are, on the right path. We need to continue to ask these questions.
So shifting gears a little, Dr. Goodman, I wanted to ask one quick question. You have been a leader with the NCI-GI Steering Committee. You've been the recent recipient of the prestigious NCI-R50 grant to support your efforts with NRG. There's a lot of people asking about this grant mechanism. Could you tell us about R50 and any advice you have to junior investigators looking to build their career with NRG?
I think a big part of it is having good mentorship, and having somebody like, Ross Abrams as a mentor, and even wrote my letter for the ARC50s, having those people to help you throughout your career as a junior faculty is really important. This is a really nice mechanism for those of us who are clinical trialists and involved in the NCTN, because it's time consuming to participate in clinical trials, and we don't get paid for it. So it's not something that we have a fund that pays the PIs and for the time that we're spending enrolling patients on clinical trials. So this really is a mechanism to allow physicians who are involved in clinical research to have some way to supplement their salary to support protected time for clinical research, specifically involving NCTN trials. The other thing it sort of supports is your national involvement in, the NCTN. So I am the institutional PI for NRG at Mount Sinai. And then also I've been national PIs on some of the other studies like the CLGB 80803 trial. So all of those things are very time consuming. I mean, the amount of emails and, work that it takes to manage those trials as a PI is significant. The time commitment for, quality assurance, all of that. So this really allows us to have some way to carve out some time in our day for both the national involvements in the NCTN as well as your local involvement, because their goal is really to enhance accruals to NCTN trials. And so the other role that I have at my institution is the Associate Director of Clinical Research and sort of oversee the entire clinical research program at the Tissue Cancer Institute and really trying to build our NCTN program and increase accruals across our health system. So that's another sort of rationale for having that salary support. But I definitely recommend, for faculty or for investigators involved in NCTN trials, it's a great opportunity to be awarded some kind of, support, because otherwise we don't really have any options for that.
Well, Dr. Abrams and Dr. Goodman, I want to thank you both again for joining us. The NRG Oncology Group is supported by grant funding from the National Cancer Institute of the National Institutes of Health, and content of this podcast does not necessarily represent the official views of the National Institutes of Health. Thanks, everyone, for tuning in and wishing you all happy clinical trials.